الله ماشي.
بداية
I would like to introduce myself. I'm Muhammad Al-Arab. I work for s.a.r.l, which is the distributor of GE and Medimaps in the Middle East. Medimaps is a company that introduced the TBS software. We will talk about the TBS software now. TBS software is a detection tool for the trabecular bone score for the spine. Let me share my screen to start my presentation. Okay. لا مش فاضي. اوكي. كل شايف؟
شايفينها بس مش فول سكرين.
اوكي هلا
لسه
يفترض تكون فول سكرين. هلا في حدا يعمل ادمت. اوكي هلا
يعني من ضمن التيمز هي كويسه يعني مش مشكله.
تمام اوكي.
ايه واضحه هلا بتبين بعدين.
اوكي رح نبدا ان شاء الله. فاذا بدنا نحكي شو هو الترابيكولار بون سكور. Monsieur Antoine, can you please admit the newcomers?
I will. Yes, I will.
Thank you very much. Okay, let's start about what is the purpose or the benefits from knowing the trabecular bone score of the patients. It's to identify more patients at risk of fractures and fine-tune therapy decision and improve patient management.
إذا ممكن بس إنه يمكن أنطوان إذا ساوى ميوت kindly if you can mute yourself Antoine it's affecting Muhammad sounds.
I'll mute, sorry.
Thank you.
Okay.
Great.
Okay, so let's start about the definition of osteoporosis as defined by the WHO, the World Health Organization. Osteoporosis is a silent systematic skeletal disease characterized by two factors: low bone mass and microarchitectural deterioration. This is defined by the WHO. Of course, this leads for bone tissue. It leads the bone tissue to increase the bone fragility and unacceptable risk fracture. We have two images here for a normal BMD and good microarchitecture. The other one is osteoporotic BMD and degraded microarchitecture. Okay, so the DEXA machine, as you know, it's a gold standard for osteoporosis diagnosis, but it's only giving me the BMD values, the quantity of bone over the area. Okay, so what we have missed? Depending on that, we have missed the microarchitectural deterioration. We do not have this information yet. So that's why we have lots of patients. They are, as you can see in this slide, they are fractured even if they are in the normal and osteopenic zone. Why? Because we are not looking at the microarchitectural deterioration. So we all know that supposed that it's supposed that the patients that are at risk of or at high risk of fracture are the osteoporosis patients. Since we are having 50% as this study, 50% of the fractures are occurring in the normal and osteopenic zone. Why? Because we do not have the TBS value. So how to measure the bone microarchitecture? The main problem collecting such information wasn't possible without complex procedure and expensive technology, even pain and extra radiation for the patient. So Medimaps has given the solution, which is the trabecular bone score, TBS. It's a technology. It's also a gold standard. Okay, it is mentioned in the guidelines. So it's a gold standard measurement. It is a tool, a software, okay, installed on the DEXA workstation. It extracts the bone texture information from a regular DEXA AP spine image. It doesn't require additional radiation for the patient, and it is computed in only 3 seconds. Okay, it gives us a separate report other than the DEXA or the BMD. So what is the TBS software and what is the TBS score? TBS score, sorry. TBS stands for trabecular bone score. Okay, it is not it's not a direct measurement, but it is a texture analysis. It analyzes the grayscale of the image that is already scanned by the BMD software or the DEXA machine. While BMD takes the aerial BMD is related to the sum of the pixels, pixel brightness. It doesn't take into consideration the pixel to pixel variation. That's what TBS algorithm does. The TBS algorithm explores the spatial variability of pixel brightness in the image, and it subtracts the neighboring pixels brightness and squares the result. So that's how this tool works. Okay. So let's take this projected vertebra image. As you can see in this place. Let me try to. Okay, in this place, number one, you can see a good trabecular, good connections of bone, and you can say that it is showing us the quality of the bone. Okay, and the second area, which is the same vertebra, also we have a bad quality of bone. So a low TBS. TBS also has a reference curve, just like BMD. The green zone is low risk fracture, suggesting normal bone microarchitecture. The yellow zone, which is the medium, and the red zone, which is high risk of fracture or the degraded bone microarchitecture. Okay. So what did the TBS added to the what clinical value added TBS? It helps identifying the new patients that have a high risk of fracture. Let's say we have those 100% of all those fractures which are occurring in the normal, on the osteopenic and osteoporotic zones. We already said that 50% of the fractures are occurring in the normal and osteopenia zone. Okay, we are talking here about the fractures. So, and the other 50% are occurring in the osteoporosis zone. So this is only when we look on the BMD. If we added the TBS value for those patients, we will have a reclassification for 21% of the normal zone. Okay, 21% of those 50% fractures, they are reclassified as underestimated because we only looked at the BMD. 29% of the fractures in the osteopenia zone were reclassified also because they were underestimated by only using BMD. While we have in the osteoporotic region, 5% they were reclassified, but they were overestimated because they were overestimated. Okay, so what did the TBS do? TBS plus BMD is better than BMD alone. Okay, because we were looking only about at the quantity of bone over the area. We did not look how this bone is distributed. Is it well distributed? Is the quality of the connection is good inside this vertebra or not? That's why I can have good quantity and acceptable quantity, but the distribution of this quantity is bad. So TBS, as you can see, either than having 3 zones, we have 9 zones. Okay, each one has a higher fracture risk. You can see here how the software works. You have the DEXA scan. The DEXA scan, in 3 seconds, you have the, as you can see, this dotted image in the TBS report. And you can see the graph and the additional results table and the flux adjusted for TBS. I will talk about it in the next slide. Okay, so this is the report. If you took this example, okay, we have a patient that have this value, let's say BMD1, okay, which is equal to the other patient which will be having also the same value of BMD. And we have 2 patients that they have the same BMD. Okay, if we are looking only at the BMD, we will give the same interpretation for those patients because they are the same. Okay, but we did not look here at the TBS, at the architecture of the spine. The first patient was having a good TBS, so the first patient is normal. But the second one, even if his BMD was good, but the distribution of the quantity of bone was bad. So he had degraded bone. So the interpretation of the second patient was wrong because I only looked at the BMD. So what is the FRAX adjusted for TBS? As you can see, as you know, John Keynes, who invented the FRAX, all of you know about the FRAX, and maybe visited the website of John Keynes in the Sheffield University website. You can find the calculation tool which calculates FRAX depending on risk factors. So he found that also the TBS value is considered as a risk factor. So when the value of the TBS is high and is good, the risk factors is lower than and becomes lower. And if the TBS value is low, the risk factor becomes higher. That's why it is included now in the new FRAX, which is available on the website and in the GE software. In the TBS software. Okay, that's the calculation tool on the website. As you can see here, after you calculate the FRAX and you put the risk factors, you answer the risk factor questions. You will get here on the notification. If you have a TBS value, click here and adjust with TBS. If you click on it, you will get another page. You put the number of TBS inside it, and you calculate. You will get another value of FRAX. As you can see here, and in some guidelines, the first FRAX, the doctor might say it's below the guideline, so I won't take any decision for therapy. While it is actually, and because he did not look at TBS, actually the risk was higher than it should, higher than 9. It is 12. So here he should start the therapy. That's the importance of TBS. The decision of therapy changed because of TBS. You can see here in the gold standards in the market, the BMD, the s.a.r.l. I will pass them very fast. The TBS, as I said, it is a gold standard now. Okay, the morphometry and the body mass, body composition. Okay, talking about the treatment initiation and monitoring. Of course, I can monitor TBS as I can monitor BMD, and I can see the change if it is progressing or it is decreasing. I have two types of treatments. The anti-resorptive, which slows down the bone destruction, as the biphosphonate and the denosumab, and the anabolic, which rebuilds the bone, as the teriparatide. Okay, and about TBS, you can see here that international guidelines recommends the use of TBS. Okay. Okay, about the TBS publications and the clinical routines. About primary osteoporosis, it is mostly related to aging process or natural causes. About the secondary osteoporosis, like diabetes and HIV, etc., oncology, we also found that TBS helps to detect or predicts the presence of those disease better than BMD. Let's see how. Like in diabetes, for example, diabetic patients with poor glycemic control present an elevated risk of fracture, but paradoxically, their BMD is higher than in healthy patients. The solution: the poor glycemic control has been associated with high fracture risk and lower TBS values. TBS has been shown to be an excellent predictor of fracture risk in diabetic patients independent of BMD. TBS has been included, and it's included officially in the guidelines for the management of diabetes by the International Osteoporosis Foundation, as you can see in this image. So FRAX adjusted for diabetes, it is included here, okay, and the as well as TBS. Okay, let's take this clinical case. Jane Doe 2 is 58 years old, white female with polyarthritis rheumatoid. For the last 25 years, she had 2 total knees and 1 elbow implants. She's receiving classical PR treatment, methotrexate, and Atemra. Osteopenic BMD spine L1, L4 is T-score is -1.3, which is osteopenia, and femoral neck T-score is -1.7. Normal partially degraded structure, the TBS was good, normal, equal 1.311. The FRAX for MOF, the major FRAX is 11 and 1.3 respectively for hip. Adjusted for TBS, يعني the adjusted FRAX for TBS remains the same because her TBS is good, 11% and 1.2%. Okay, 2 years later, all these values are below the Swiss intervention threshold for treatment. The doctor will see the results and will not initiate any treatment. 2 years later, Jane had a major PR flare. She then received a daily dose of glucocorticoid. It is explained here, 15 milligram, then 10 milligram, then 5 milligram. Okay, what happened when she started to take the glucocorticoid? Monitoring the TBS will shows, here you can see the glucocorticoid initiation and how the TBS started to decrease. So the stability, the BMD was stable, okay, but we are having a decrease in the TBS over time. Okay. So no bone specific treatment was given, as this was a beginning of TBS. And physician not confident enough yet to change patient management on sole reason that TBS changed, regretted as patient ended up with hip fracture from a standing height fall. صار عندها fracture لأنه the TBS was decreasing. الحكيم هون ما كان عنده الخبرة الكافية بأنه يتعامل مع هذه البيشنت. So secondary osteoporosis negatively impacts bone structure, but not always density, as in this case. And here the density was stable, but the sole factor was decreasing with the TBS. The patient ended with a hip fracture. Okay, so taking glucocorticoids negatively impacted TBS, corresponding to an increased risk of fracture. Thus, independent of BMD, TBS should be considered to measure bone quality and have the full patient's picture. Okay, في عنا clinical case ثانية. We have another clinical case, but I will try to pass it quickly. And we have here another example. Okay, as you can see, the right decision was made. The denosumab shows that the TBS was increasing over time. Okay, so this patient was treated good, and I will distribute the presentation at the end. Okay, what are the outcomes? As we said, the clinical outcomes about TBS: identify more patients at risk of fracture, fine-tune therapy decision, and improve patients management. Operational, easy to install and use with no additional exam time or no additional radiation for the patient. Financially, it increases the value of existing DEXA practice with more patient referrals and additional and new revenue. Retrospective analysis identify existing patients. The existing patients, before TBS, we can also analyze them in risk groups and contact their referring physicians for earlier repeat scan. Patients are asking for it, enhancing word of mouth recommendations. Okay, نحن خلصنا البرزنتيشن. بس بدي أعرض أنا study عملت ب 2 centers. أوكي، شايفين الإكسل شيت؟ Hello? Okay. And here we have, for example, this patient. Okay, his major fracs. His major fracs was 7.3. It is decreased because he has a good TBS, as well as this patient. Okay, but here, we had 5.4. It became 2. Okay, let's take some osteopenic BMD. Okay, this patient, for example, was 8.5 because he was overestimated. His true value is 5.6 because he had good distribution of bone and a good TBS. Let's try to take another patient. Okay, this patient, for example, إذا مثلا بالجايدلاينز مرات بيكون نمبر 10% هو هون بدنا نبلش نعمل decision للتريتمنت. This patient value is 8.6 fracs MOF. They adjusted for TBS, it became 12. هون if we did not start or initiate the therapy, the patient will come with a broken bone. Okay, that's why it is very important. And here you can see in the osteoporosis, or also we have also overestimated patients. Okay. As well as here, for example, we have underestimated patients. Okay, let's take the other study. Okay. Can you see this image? Yes. هذه شرحنا عنها. So okay, this is a different one. Okay. Also same examples where here we are talking about a patient that have a good TBS. That's why his fracs decreased. Okay. The other examples almost the same, overestimation. Okay, here we have a couple of examples. This patient was his major fracs was 9. It became 11, and this one was 8.8 and became 10.8. Okay, those are very important cases since they almost most of the guidelines will initiate the therapy if the fracs value is over 10%. Okay, let's see finally here the osteoporosis. As you can see, there are a couple of examples. Okay, so my presentation is done. If anyone has any question, we can start with the questions, and Mr. Nico will continue with you. Hello.
الو الو دكتور رامي.
دكتور سمير تفضل اسأل سؤالك.
بس بدي أسأل، يعطيكم العافية وشكرا دكتور رامي على تنظيم المحاضرة وشكرا لضيوفك الأكارم. سؤالي إذا في احنا بنعرف في عندنا مشكلة بالديكسا للمرضى اللي عندهم اوستوارثرايتس او ادفانس اوستوارثرايتس، في مرات بيطلع عندنا فالس اوستوبوروتيك وبتكون مش ماشي. هل في النظام الجديد اللي بيستخدموه هم في مراعاة لهاي الأشياء ولا لا؟
I can translate the question if you want. He's asking about the osteoarthritis. It is affecting BMD, as you all know. He's asking about the effect of osteoarthritis on TBS.
Through studies, it was shown the very limited impact of osteoarthritis on TBS for future reason, but the demonstration is that when vertebrae or even the entire vertebra must be excluded for BMD reason. They can be kept for the study. The spine values can still be used to compute TBS on them.
دكتور سمير
Another
الجواب
question I can ask you. واضح عندي. واضح الجواب واضح.
Yeah. He said that the
Hello?
answer is clear. Yeah, go on.
رامي سامعني؟
سامعك دكتور سمير. Next
another
question.
question.
Yes, please. Yes.
For CA patients إذا كان في follow up إلهم باستخدام ال TBS أو لا، زي ما سووا للمرضى تبعون الديابيتك patients، كان في ناس يعني كان عندهم دراسة زي هيك أو لا؟
Okay, he's asked. Yeah, go ahead, doctor.
Dear Antoine, he's asking whether if there is an interpretation between TBS and cancer, any study about cancer patients and its relation with TBS.
They are, in a sense, I think we'll have to go through the different studies, but also the treatments of cancers. And for example, one of them could be breast cancer. And when anti-aromatase treatment will have a negative impact on both BMD and TBS, and thus the importance of doing a follow-up both on the density of bone and its microstructure, because the different treatment that can be provided, either they are anti-resorptive or anabolic, can have an impact. And so it is good to have TBS to do a follow-up on the bone health, both density and structure.
Okay, thanks, sir. Thanks.
Thank you, Antoine. Any other question, please? في حدا عنده أي comment أو questions؟
دكتور أحمر في عنا كتير guests فاتوا مؤخرين. They joined us later on. So we'll record the meeting and send them the recorded meeting and the presentation also.
Thank you.
Sorry, I think it will be already sent to everyone who participated in this meeting. It will be automatically sent.
No, we didn't provide the email. We will have it and we will send it to the. Either I will send the email later or I can send them by WhatsApp. Okay. Dear Antoine, it's just a comment that we have recently more than 10 years of practice in following our patients in Jordan regarding osteoporosis. As we have an osteoporotic clinic more than 10 years since 2010, for example, and before. What happened that as the new recommendation and the previous recommendation and guidelines is that patient should start with should have a drug holiday. Most likely, if you can just comment that the benefit of TBS regarding drug holiday, as sometimes we have patient without a high risk and he's still osteoporotic and more than 5 years on bisphosphonates or other treatment. So kindly, if you can comment on that, please.
I think it's one of the slides that best explained what you're asking is the slide presented by Mohamed on reclassification. And indeed, I think one of the practices in terms of drug holidays is when you assess patient who has been under treatment for maybe a few years, and you see they're still identified as osteoporotic by BMD, but if they have a high TBS and linked also to a good trabecular structure, maybe feel more confident to engage a drug holiday because of the status, because of the low density having a good trabecular structure. This is key. I think it's one of something that has been expected or seen through some different practices.
Thank you.
Mm-hmm.
Any other questions or comment? I guess no answer, no questions.
Maybe I can complete with some of the global recommendation for
Yes,
the
please.
use of TBS.
Yes, please.
TBS
We have different senior, different levels, senior, junior, and consultants in attending this presentation.
All right. In general, and as stated, also TBS is a good complementary tool for a bone assessment. It's not the only one, but it is almost the only available tool that allow trabecular bone assessment in clinical routine. Because it's a non-invasive, it's quickly, because we use the same scan as for BMD, and so no need to rescan patient. And in that sense, of course, for certain very advanced disease, biopsies might still be needed, or CT exams, but at least it is available for the grand majority, and it could be done for every patient who go for a BMD examination can come with a TBS. In terms of clinical practice, we recommend that TBS, for clinical validation, that a TBS is for patients from the age of 20 years old, not underneath. Underneath it can be computed, but it should be for maybe investigation or research, but not for clinical routine. There is a BMI range, because as the algorithm, and that's the way Mr. Mohamed presented the TBS, that you understand that there are some corrections of through BMI, and so the BMI range is between 15 and 37, but already including a large range of patients. So these are the recommendations in the use for TBS. And in general, of course, TBS is always to be used with BMD together. Together, they are a great way not only to discover more patients at risk of fracture, but as also was mentioning, is the ability to do treatment follow-up. You had a good question, Dr. Ahmad, on, of course, the questions that physicians can ask themselves: should I initiate a treatment? Am I confident to go on drug holiday? TBS is an additional, not only, but an additional tool that will help making decisions, treating, not treating, what type of treatment, how should I treat? Is my anti-resorptive, my complemental and vitamin D or calcium or my bisphosphonate, is it enough? Because all patients respond differently to treatments. It's also not only monitoring the density of bone through BMD, but adding TBS to it can be a great value added to your overall bone health assessment.
Thank you, Mr. Antoine. Any other question or comment? I guess no other questions or comments. We would finish. Just a moment, please.
It's one of the slides I can share while we wait for Dr. Ahmad is this. I was to illustrate what I was talking about earlier with aromatase inhibitors. as you can see, the difference. So both this treatment we know has a negative impact through breast cancer on bone health. And what we can see through this graph and the response of patients without any treatment, both bone density and TBS go down. But in some patients with a bisphosphonate, you can see that as BMD goes up, you have a negative maintenance of your TBS. And what it is interesting here to see is the structure of its bone and to see if the negative maintenance doesn't become in some patients as a degradation of the structure, and thus again the idea of what is the impact on my patients and whether for some of them should I adjust for a different type of treatment.
Thank you, Mr. Antoine. I don't think that there is any question or comment. Do you have anything to add?
On my side, I don't. You feel free to later on through GCTS to reach out to us and ask any further questions.
Thank you very much. Any other question, or shall we close this presentation or this webinar? Okay, on behalf of our society and on behalf of our colleagues, I would thank you both in MidMaps and Engineer Mohammed May for helping for having this presentation, comprehensive presentation about the TBS, which is, we hope that we will have it in Jordan as we have in some institute, and I know that you are looking forward in order to implement this software in our devices in order to interpret and improve our practice. كل الشكر لكم و thank you very much وبشكركم مرة ثانية.
You're welcome. Thank you for your time.
Thank you.
Thank you.
Thank you, Dr. Ahmad.
Thank you.
Thank you for the attention. Have a good rest of the day.
Thank you.
Thank you all.
Welcome.
Thank you.